Broadcasting and streaming live from the WIDU Community Room.
The WIDU Radio Network. WAGR in Lumberton. WYDU in Red Springs. WEWO in Laurinburg.
Making rounds live on 99.7 FM, 1600 AM.
We air every second and fourth Tuesday of the month.
Making rounds live.
The purpose of this show is to bring you information on health and wellness.
Here's the host of Making Rounds Live, Omega Jones.
Thank you so much, Ray. Welcome to another edition of Cape Fear Valley Health's Making Rounds Live. I'm your host, Omega Jones. Folks, can you believe that we are only a few days away, too, as a matter of fact, from Thanksgiving? And I hope that everyone is getting their holiday plans together so you can enjoy great meals together with family and friends. But before we get distracted by all of the thoughts and of holiday festivities and the turkeys and the hams, let's talk about some community health issues. One thing we want you to know is that November is COPD Awareness Month, and COPD is a very common issue in our area. So today we have Dr. Arlene Locklear from Cape Fear Valley Pulmonary Medicine to talk about COPD today. And we'll talk to Dr. Michael Bass. He is a resident doctor at Cape Fear Valley Health, and we're going to talk to him about the flu vaccine. Now, ladies and gentlemen, I do need to let you know that due to the topics that we'll discuss today, this is not a time for you to self-diagnose. What I want you to do is make sure you find yourself a healthcare professional, because everything that we discuss here on Making Rounds Live is for informational purposes only. Now, as I mentioned earlier, COPD is a very serious lung issue, and it can make it very difficult to breathe. According to the American Lung Association in 2021, there were over 627,000 people living with COPD right here in North Carolina. Now, COPD is a major cause of disability in our country, and according to the Center for Disease Control and Prevention, it is the sixth leading cause of death here in North Carolina, and it affects more than 14 million adults in the United States. Finally, more than half of those diagnosed are women, and many others don't even know they have COPD. So, ladies and gentlemen, this is where we bring in Dr. Arlene Locklear. Dr. Locklear, welcome to Making Rounds Live.
You're welcome.
Dr. Locklear, first, could you tell everyone what COPD is?
Well, COPD is just a big name for chronic obstructive pulmonary disease. So COPD entails chronic bronchitis and emphysema. So that's basically what COPD. And 99.99% of COPD is associated with smoking.
Wow.
Whether it be primary smoking or secondhand smoking. And so, like you did say, it's one of the primary causes of shortness of breath that we see in our clinic. And there are a lot of people who don't even know they have it. So it's a major problem, you know, in our country, and especially in this area.
Dr. Locklear, how does COPD make breathing so difficult?
Well, what it does is basically, you know, like I said, it's chronic obstructive pulmonary disease. So what the smoking does, what the cigarettes do, is basically destroy the small alveoli, or the small little air, you know, tissue within the lung. So it basically destroys the lung tissue. And so those patients they're not able to ventilate, they're not able to exchange air like they would normally. And some of them actually get areas where, you know, they get a lot of fibrotic lung disease, so they're left with scar tissue. So it's basically an abnormality within the exchange of oxygen within the lung tissue.
Dr. Locklear, can a patient have symptoms before they even notice that they have the breathing issues associated with it?
Yes, they can. I mean, because some people, maybe it may not be so much shortness of breath. It may be a cough, because one of the symptoms of COPD is a cough. You get that chronic cough. And then a lot of individuals, especially as they get older, they think that, well, I'm getting older. That's why I'm short of breath. I'm 50 years old. That's why I'm short of breath. But that's not always the case. Mm-hmm. So you can have other symptoms before you get the shortness of breath. But most of the time, you're going to get the shortness of breath. Okay.
Now, what are the other symptoms?
The other symptoms is the cough, a chronic cough. And then, of course, chest discomfort. They can feel like a tightness in their chest. And basically that's because of the exchange of oxygen and because of the obstruction of the airways and the bronchi of the lungs, so they can get a tightness. Some individuals may feel as if they're having pain, which I'm not so exactly sure whether the pain is more related to the shortness of breath or is it because they're having such a difficulty breathing. Bending over. They tend to feel like they can't bend over and tie their shoes like they used to be able to do. Okay, but because they're pushing the diaphragm up. Yeah. Laying down at night, they get short of breath. So, but the most common one is shortness of breath, the chest tightness, and of course the cough.
Ladies and gentlemen, Dr. Earlene Locklear from Cape Fear Valley Pulmonary Medicine, our in-studio guest today. If you would like to be part of this conversation, 2 ways you can do it. First of all, you can give us a call at WIDU, telephone number 910-483-6111. Or if you're following the live stream by way of Facebook, you can leave the questions in the comments section, and Lindsay will make sure that we get those questions answered for you today. Also, I want you to share this broadcast. The reason we are going to discuss some very important information today, and we do not want you to try to be the person to remember every single thing that we discuss. So it's easier for you to share the broadcast, and then that way, whoever you share the broadcast with, they can get all of the information firsthand themselves. Ladies and gentlemen, once again in the studio, Dr. Earlene Locklear, today's guest on Making Rounds Live. Dr. Locklear, are there ways that we can test for COPD if a person is concerned that they may have it?
Well, the first thing that people usually get when there's shortness of breath is a chest x-ray. Chest x-rays don't always show COPD. It depends on the severity of the disease. Yes, you can get a chest x-ray, and sometimes I can look at that chest x-ray or someone else can look at that chest x-ray, and you see hyperinflated lungs where the lungs look larger than they should be. You can see areas where the diaphragm is kind of flattened out. And also, depending on the type of COPD they have, you can see holes or large holes in the lungs. Okay, so that is kind of a way to kind of look and say, well, this patient probably has COPD based on what their chest x-ray looks like. CT scan is another way you can look at a CT scan and you see airways, you see differentiation in the lung where you can see areas of the lungs, and basically you can see COPD on a CT scan. Okay. Now, the true diagnosis for COPD is a pulmonary function test. Okay, so a pulmonary function test is there's different ones. Sometimes the primary care doctor can do what we call a simple spirometry, which is done in their office. So they have a little machine sitting on the top of a table, and they have the patient blow the candles out, you will. So that's a simple spirometry that a primary care physician can do. When you go and see a pulmonologist, what a pulmonologist 9 times out of 10 will do is a full pulmonary function test, which will determine how bad your lungs are. So it will actually give you a percentage of your lung function. That's what the pulmonary function test. So it tells you whether you have 50%, 60%, 40%, or 30% of your lung function. So that's the true diagnosis of COPD.
Dr. Locklear, do the symptoms change as the disease progress?
They do. They get more short of breath. They become more dyspneic, and so they get to the point where they may not realize it, but other people may see, like they're walking, in the Walmarts, they're walking down the road, and then you may be having to stop and wait on them. Okay, so they're getting to the point where they have more exercise associated shortness of breath. They can't do as much as they used to be able to do. They have to stop when they make their bed. They have to stop when they're cleaning their house. All these things, they have to stop and take breaks because they're more short of breath. Okay, their cough may get worse. Instead of coughing in the morning time, they may cough all day long. Wheezing, which is another symptom, that I forgot to tell you about. They may wheeze more often, okay? But the most common thing is they notice that they can't do the things they used to be able to do. They get short of breath much quicker.
It sounds like the symptoms are similar to asthma.
They are similar to asthma. And sometimes, it's difficult to differentiate asthma from COPD because asthma is hyperreactive airways disease. Okay, that's what asthma is. Asthma is not COPD. Okay, so an asthmatic is an individual who their airways become sensitive to something, whether it's an environmental agent or chemical or whatever it is, and they get short of breath. Their airways obstruct, so they get small, or they start wheezing, they start coughing. So the asthmatic is more like a hypersensitivity airway, okay? Whereas COPD is basically something the patient did smoking, to destroy their airways, okay?
Yeah.
Now, the treatment is similar. Both diseases are treated with bronchodilators, albuterol, and both diseases are for the majority of the time are on steroids. So the treatment is similar, okay, but they're totally different diseases, okay, and the symptoms also are similar. Asthmatics tend to respond better to steroids than a COPD with because of the hyperreactivity of the airways and anti-inflammatory in the asthmatic. Now, if you do a pulmonary function test, you can usually tell the difference between an asthmatic and a COPD also, okay? And then sometimes you may do a pulmonary function test on an asthmatic and it may be totally normal. That does not mean they don't have asthma, okay? That means they were having a good day when they did the pulmonary function test, okay? So remember, because it's hyperreactive airways disease, unless it's someone who has severe asthma, then they'll have an abnormal test.
Dr. Locklear, is COPD a senior disease, or can anyone at any age have COPD?
Anyone can get COPD.
Wow.
I mean, men, women. If you see a young person, like a 20-year-old, who looks like they have COPD, you have to think of something else. Like there's a disease called alpha-1 antitrypsin deficiency. Those individuals, for all intents and purposes, look like they got COPD. So you have to rule those individuals out. But once that person starts smoking, okay, that's when they start destroying the lung tissue, and it can be any age.
Dr. Locklear, you mentioned COPD is more common in our area or in our region than in any other places. Is smoking the reason why, or are there other reasons?
Smoking, in my opinion, is the reason why. As you know, we grew up in Robeson County.
Yes, we were talking about that.
And Robeson County was tobacco country.
Yes.
Okay, it was tobacco country. My family grew tobacco, and probably your family grew tobacco, and some people in here, their family probably also grew tobacco. So when I was growing up, everybody smoked.
Yeah.
Okay, if you didn't smoke, you were exposed to it.
Secondhand.
And so you would think that over time that it would have decreased, but it almost seems like it's either increased or it's the same. So you still see a lot of people grew up smoking, and they started at an early age. Majority of people that I see was 14, 15 years old when they started smoking.
Wow. Yeah, that's about right. 14 or 15, that's about right. Because we had smoking sections in high school. So that's right.
Right. So, yes, when I grew up, you could smoke everywhere. Yeah, you could go to high school, go outside, and you smoked. Yeah, so you had places you could go outside and smoke your cigarette.
Wow. Now, you mentioned earlier, Dr. Locklear, that anyone can come down with COPD. Now, the factors, do the factors increase with the risk themselves, or am I saying this right? Can anyone come down with COPD, or are there factors that can increase your risk of COPD?
Well, I mean, yeah, the kind of work you do, it doesn't increase the risk of COPD, but it also adds to the COPD, if you will. So, for example, if you work in a factory and you're exposed to a lot of chemicals, the kind of work that you do, if you do a lot of construction, if you do a lot of painting, those type of things, the environmental things can make the COPD worse because it adds to the disease. Okay, so you also have to, when you're trying to diagnose someone who comes in with shortness of breath, you have to say, well, yes, they're a smoker, but what kind of work did they do, or do they do? Okay, it can also make it kind of doubles, their symptoms, if you will.
So those are the where they work. Those are other things that can contribute to COPD along with smoking? All right. Now, what can people do, Dr. Locklear, to lower their risk of COPD?
Stop smoking.
Okay. Is there anything other than stop smoking?
That's it. Stopping smoking.
That's it?
That's it. Stop smoking.
Wow. Just that simple.
Well, patients will tell you it's a hard thing to do, and I don't know. I tried it when I was little. Most people did in this area. It didn't do anything for me, so But that's it. Quit smoking.
Stop smoking. Plain and simple.
Smoking.
Oh my goodness. So.
But you also, a lot of people will tell me that someone also told them, if you have COPD, you quit smoking, your lungs regenerate. They repair themselves. Now you have to remember that's not true. So once the damage is done, it's done.
It's irreparable.
Okay, but when you stop smoking, at least you don't keep getting that damage from the cigarette. Okay? So that's it. Quit smoking.
Okay. Ladies and gentlemen, Dr. Earlene Locklear from Cape Fear Valley Pulmonary Medicine. She's our in-studio guest today on Cape Fear Valley Health's Making Rounds Live. Dr. Locklear, how is COPD diagnosed?
With a pulmonary function test.
With a test.
That's the diagnosis.
And those tests go beyond the initial screening? Okay.
The initial screening, like I said, is usually a chest X-ray. To make sure they don't have something else going on in the lung, like fluid buildup, pneumonia, something else. But the main diagnosis is the pulmonary function test.
Yeah. And after diagnosis, what's the next step for patients?
Next step, of course, is education. Smoking cessation, and then treatment. Put them on medications.
Do you all have patient navigators like they have at the cancer center to help patients understand different things?
Right now, we don't really have an actual COPD navigator, but our nursing staff, our navigator at our clinic does talk to patients, about smoking, their treatment. So we do have people. We don't have a nurse navigator per se, but the people in our clinic do talk to patients. And we have a navigator that's not COPD, but she does other things. But she also talks to patients, if she can, when she has the time. But I sit down with my patients a lot of times and talk to them about COPD, about, what they can do, how they can help themselves, what to avoid. So we don't really have a nurse navigator per se.
Let's talk about the lung nodule clinic. How do COPD patients fit into?
Only seeing maybe 4, 5, 6 patients a day. But now we're up to seeing 30, 40 patients a day. So the lung nodule clinic has truly expanded itself. As far as the COPD, as you know, one of the risk factors or the things that COPDers are at risk for is lung cancer, okay, because of their history of smoking. So they're at risk for lung cancer because of their smoking. And the more years they smoke, the more at risk they are. So now the guidelines, used to be years ago, the guidelines for a COPDer was to do a yearly chest x-ray, to see if they had developed a mass or to see if they had developed a nodule in their lung. Okay, so now the guidelines has changed where it's now those people that are at high risk, 50 years old, smokers, they need to have a low resolution chest CT. So they need to have a chest CT of their lungs on a yearly basis, not a chest x-ray. Because depending on if they have a small nodule in their lungs, which could or could not be an early cancer, you may not see that nodule on a chest x-ray because of the location. And so certainly on a chest CT you can see that nodule. So what the lung nodule clinic does is we follow patients, or we see patients with lung nodules, and depending on the size of the nodule and the risk factor of the patient themselves, then we may do further testing, and we follow that patient with that nodule. Or we may biopsy that nodule, or we may do other studies for that nodule depending on the size of the nodule. So that's what the lung nodule. So we kind of get things done quicker, if you will.
Okay. Ladies and gentlemen, Dr. Earlene Locklear, our in-studio guest today on Making Rounds Live. Dr. Locklear, what if COPD is left untreated?
Well, if COPD is left untreated and the person continues to smoke, they'll become more short of breath. They'll become more dyspneic. They will get to the point where they can't do their, daily routine chores. They will eventually end up on oxygen. And then eventually, yes, in time, they will succumb to their disease. Okay? And also the other things that COPDers sometimes tend to complain of is bloating, because they swallow air. Okay, when they're breathing, they swallow air a lot of times because they're huffing and puffing. They're breathing with their mouth. They're trying to get air in, and some of that air is going into the stomach, and so they feel bloated, and so that also affects their breathing, affects their eating, because they feel full all the time. They feel like they can't eat.
Yeah.
So yes, they do. And then one of the other things, that's loss of weight. You don't normally see COPDers gaining weight. Now, something that patients do complain of with COPDers is, a lot of COPDers will tell you that they smoke to not eat so much. they don't eat a lot if they smoke.
Oh, okay. Yeah.
Okay? And so when they quit smoking,
They start eating a
they
lot.
start eating more because now they can taste their food. It tastes better. Okay? And so that's one thing they do not like when they quit smoking is they start gaining weight because food tastes better.
Wow. Dr. Locklear, let's talk about the support groups. Are there any support groups for folks with COPD and for COPD caregivers?
Right now, we don't really have any support groups at Cape Fear Valley.
Okay.
I mean, other than the physicians themselves, talking to the patients, our nurses. That's something that we need to look into. So we don't really have any support group for COPD. We have support for our lung nodule clinic, because that's their clinic for the cancer and the lung nodules. That we have a navigator for that. But as far as the COPD and the pulmonary clinic, we do need to, and we're working on that because there's a big population of patients with COPD.
Wow. Dr. Earlene Locklear, ladies and gentlemen, today's guest on Cape Fear Valley Health's Making Rounds Live. Dr. Locklear, if there are any of our listeners out there who are worried about COPD, what would you tell them?
If they're worried about COPD, they can, and if they have a primary care doctor, of course, that's your first step. Talk to your primary care doctor. And then sometimes the primary care doctor themselves, can treat the COPD.
Okay.
Because, like I said, it's breathing treatments, bronchodilators, and steroids. But if the primary care doctor or the patient thinks that they need a specialist, like a pulmonologist, then yes, the primary care doctor can refer the patient to us or a pulmonologist. But normally it starts with the primary care doctor and then the referral. Now, some patients they can refer themselves. If the pulmonary tests, we do those in our office, and so sometimes we do PFTs for the primary care doctors, and then they get referred. So that will be the first step: is talk to your primary care doctor if you have one, and then if you need, then they can refer to us for more specialized help.
Yeah. And finally, Dr. Locklear, what is the one thing that you want listeners to take away from this interview today?
The one thing from this interview is that COPD should not be taken lightly. People do die from COPD, and it's a terrible death. Because if you think.
Now, Dr. Bass, my personal physician, he is every year, flu shot. Got to get your flu shot. Why is it so important for us to get our flu shots every year?
So this is a question I hear all the time, especially from my younger, healthier patients that we have at our residency clinic. Even if you are young and healthy, the flu shot decreases the symptoms that you have, decreases the amount of time that you have the flu, and decreases the amount of time that you could spread the flu to others, such as those who are immunocompromised or those with other pre-existing conditions like COPD that could have worsening adverse effects if they were to have the flu in general.
And we're in flu season right now, correct?
Yes, ma'am.
Okay. When does flu season end?
So flu season typically is in the winter months. Usually we see the biggest spikes between December to February. So that's usually, and it's pretty much because it's now getting colder, you're spending more time indoors, you're spending more time being in close contact with others, so it increases the risk of possibly getting and contacting the flu.
All right, so it's too late to get a flu shot now?
No, ma'am. Since it still goes until February, it's still plenty of time to get the flu shot. We were just giving it this morning in the clinic.
All right. Ladies and gentlemen, Dr. Michael Bass today on Making Rounds Live. We're talking about the flu vaccine and the flu shot. So, Dr. Bass, what are some of the other misconceptions? Because we've already discussed that big one. The flu shot is going to make me sick. So, what are some of the other misconceptions that you've heard about the flu itself or the flu shot?
Yeah, so there's a few misconceptions I usually hear. One of them is that if I get, Doc, I hear this all the time, Doc, I got the flu shot last year and I got the flu still. And that kind of stems actually from how the flu shot's produced. Usually in February, right as soon as flu season ends, the World Health Organization has to kind of predict what viruses and what strains of the influenza virus are actually going to be the predominant strains the following flu season. So they have to predict a year in advance, enough time to actually mass produce the virus. Some years their predictions are better than others. Depending on how well they predict the strains will determine how well and how efficacious that vaccine actually is. Another one, and we kind of already touched base with it, I got the flu shot and it still made me feel like I got the flu. And that's because, like I said, it's a trial run. You're getting exposed to a part of the virus. So therefore, your body's still mounting an immune response. But this is actually what we want to happen. And then one of the other misconceptions that we hear all the time in the clinic is, Doc, I'm allergic to eggs. I have an egg allergy. I even get anaphylactic reactions if I eat eggs. And that's actually stemming from the most common type of the way they produce the vaccine is actually through eggs. They actually inject a live virus into embryonated eggs, let the virus replicate, harvest it, and then they get that one piece that they want to use for the vaccine, and that's what actually gets injected in the vaccine. Even though in the olden days there was a lot more egg protein in the vaccine, it's actually still there, but it's at such a smaller concentration that those that even have severe allergic reaction to eggs, it's still recommended by the CDC, the World Health Organization, to get the vaccine.
All right. Now, you mentioned the eggs. So the current flu vaccine is still made the old way, or is it made like the COVID vaccine using the newer technology?
So the vaccine's actually made in there's three different ways the vaccine's actually made today. The old way, which is with the embryonated eggs, and how that goes is essentially they get a embryonated or fertilized chicken egg. They inject the live virus into that egg and allow it to replicate because the chicken egg has nutrients and things that the virus needs to grow. After it's replicated enough, they harvest the virus, essentially kill it, and then they purify it and filter it to where they get that one piece that they want to use for the vaccine, that piece that the body can recognize. The other ways they can make it is through a cell culture way where they use mammalian cells, similar to how the egg way works. They just inject normal cells, do the same process over again, harvest that one part that they need. Finally, there is a recombinant way, and without going into too many details how it works, essentially they use a kill virus, let the virus act kind of like the flu, but instead of being able to replicate in the body, it just was able to replicate that small piece, and in doing so, you only get exposed to, yet again, that small piece of the virus that we want you to be exposed to.
Ladies and gentlemen, Dr. Michael Bass, he is in the second year of the internal medicine residency program at Cape Fear Valley Health, and we're talking about the flu shot today. So where can people get the flu shot?
So actually, the CDC has a really good link on their website to show you all available areas that you can get the flu shot. But typically, most of your pharmacies, your primary care physician usually carries it, and your local health department carries it. But like I said, you can look at CCP about if you're considering doing that option.
So the children and older adults, they should consider the second option?
Typically, the first option is fine. Just your normal standard intramuscular shot is perfect for most people.
Okay. And finally, Dr. Bass, is there anything else that we need to know about the flu or the flu vaccine that you want to make sure that our listeners know about and our viewers know about today?
Yeah. I kind of already touched on this before, and pretty much with the flu shot, even if you're young, even if you're healthy, somebody that the flu, even if you get it, will only cause some minor symptoms. You're not getting the flu shot just because of you. While yes, you get the benefits of decreased symptoms for yourself and decreased time that you'll have the flu, the big thing that I touched on earlier is that it decreases the time at which you could spread the illness to someone else. Someone that may be immunocompromised, that may have breathing issues, somebody that if they were to get the flu would have much more severe reactions, including hospitalization if they were having the flu.
All right. Well, ladies and gentlemen, Dr. Michael Bass, he is in the second year of the internal medicine residency program at Cape Fear Valley Health. And thank you so much, Dr. Bass, for being on the broadcast today.
Thank you for having me.
Well, ladies and gentlemen, this wraps up another edition of Cape Fear Valley Health's Making Rounds Live. Please join me in thanking today's guest. First, Dr. Earlene Locklear from Cape Fear Valley Pulmonary Medicine. We talked about COPD. Also, Dr. Michael Bass, one of the resident doctors at Cape Fear Valley Health. We talked about the flu vaccine, and make sure you get the flu vaccine. Dr. Bass, you say we can still get the vaccine
You
now,
should
right?
still get the vaccine now. It's still, like I said, recommended in October, but still can get it today.
All right. And ladies and gentlemen, our next broadcast, make sure you mark it down, is going to be Tuesday, December 10th. And for our producers, Shaka Jordan, Ray Thomas, and Lindsey Graham, and the amazing hardworking team behind the scenes, I'm Omega Jones, continuing the legacy of Darvin Jones. Thanks for watching and listening to Cape Fear Valley Health's Making Rounds Live.
Your station for inspiration and information. 1600 AM, 99.7 FM, WIDU 6.